汉生早上请假吗？这礼拜都请假。Luis, you can sit here. So this is a 68-year-old female. This is her CSF specimen. So the patient had a very weird presentation. So she presented with some psychotic symptoms, and she went to the other hospital, and the other hospital suggesting that she might have some transient ischemia in her like a cerebral artery or something like that. And then they do an image study, and some of the radiology was thinking that the meninges looks a little bit weird. So they will rule out, could it be a meningeal carcinomatosis? And then the patient developed like a loss of eyesight and the visual hallucination. So then she came to our hospital. So she was admitted at the neurology department. And because of the radiology from the other hospital, we suspect there might be some meningeal carcinomatosis. So she received a CSF taping with cytology examination. So as we know that in the CSF, usually there should not be any cells. So if you do see some cells, despite it is has a very low NC ratio. The cell has a lot of cytoplasm, so it doesn't look strikingly malignant. But because the nuclear size is very big, and it is also eccentric, so you do identify a lot of eccentric feature along with the prominent nucleolus. So this is metastatic carcinoma. Okay. So because the patient doesn't have any history, the initial presentation is some neurologic symptom, and it's very weird neurologic symptom. So sometimes in this situation, you cannot rule out there's possibly metastasis. So the most common primary site for metastatic carcinoma in the leptomeninges here in Taiwan is lung cancer. The second most possible origin would be the breast cancer. So the patient already received the mammogram, and there's no suspicious lesion. So when I see these, I just call the neurology to ask her to do the chest CT before I do any immunohistochemical scan. So because CSF specimens were usually very scant, so the specimen that we choose to do immunohistochemistry is quite important, because if it is very scant, you use the specimen to do an additional cytospin. Sometimes there won't be lesional cell on the slides, and the patient might get delayed from treatment. So I use the PAP scan slides. I just remove the cover slides and use the slide directly for the immunohistochemical stain for TTF1. So this is a confirmatory stain that suggests that this is coming from the lung primary. So this is positive for TTF1. So the morphology is good for adenocarcinoma because it is eccentric, because the nuclear is big, because we also see the nucleoli, and it is positive for TTF1. And so the chest CT came back, they do have some mass lesion in the chest. So the patient won't need to be treated as a psychotic patient. So the next move is to do a biopsy in the lung and to do the molecular test. If it is positive for some driver gene for targeted therapy, And once she received the therapy, the neurological sign will disappear. And when I check the specimen, I noticed that in a couple days before, we already received one CSF specimen and we signed it out as negative. So this is highly unlikely, so we need to review the prior negative CSF specimen. So in this specimen, we do see some cells, and in the original requisition sheets, it already say that suspect carcinomatosis. So in this situation, we should not just give negative diagnosis. We need to confirm that these are not metastatic tumor cells. Okay, so these looks indeed like with a very similar morphology. So on just the first glance, it might not looks very prominent, very atypical, but because of the size of the nucleus is big, it is eccentric, and it appears in the specimen there should not be any of the cells. So you should consider this is metastatic carcinoma, okay? So in the loose stem specimen, this is a very big cells with eccentric nucleus. So this is metastatic adenocarcinoma. So in the CSF specimen, sometimes the metastatic tumor, most of the time they will look relatively bland looking with more cytoplasm. The nuclear might not show like irregularity of the membrane, but because these locations there should not be any cell. So this is adenocarcinoma. Okay, so luckily because the clinician sent the second specimen, otherwise the patient will still be treated as a psychotic patient. But indeed, she is actually a lung cancer patient with leptomeningeal metastasis and presented with a very weird psychotic symptoms. So the second specimen is coming from left ureter urine cytology. So because this is a washing cytology, you can see that we do have hypercellular specimen. On low power, we already see a lot of large, very blue fragment. On high power, these fragment looks highly atypical. Additionally, in the background, all these individual cells looks very atypical with high NC ratio, hyperchromasia, coarse chromatin, and irregular nuclear shape. So this is high-grade urothelial carcinoma. And usually for the upper tract washing cytology, if the patient had a concurrent biopsy, we will usually wait for the biopsy to sign out. So the biopsy was signed out as high-grade urothelial carcinoma. So this is compatible with the diagnosis. So the next specimen is peritoneum washing cytology. So she was under the impression of ovarian cancer and was received debulking surgery. So the specimen was from the SENS surgery. So because it is a peritoneum washing cytology, we do see a lot of flattened sheets of mesothelial cells. So in washing cytology, we were more easily to see these larger fragments of cells, but because it is washing cytology, it is quite common that you can see this type of architecture pattern for benign mesothelial cells. So in this kind of specimen, we were usually to see a different population which looks like these. So in this cluster, you can appreciate that the arrangement is from flattened honeycombing type of pattern to more three-dimensional architecture, you need to focus up and down to see clear in each focus. And then the cell has more prominent clear cytoplasm. The nuclear is very irregular with prominent nucleolus. So this is compatible with high-grade adenocarcinoma. With this very foamy cytoplasm, this could be a clear cell carcinoma. So this is from a relatively young female who is only 44 years old. So this is also more common for clear cell carcinoma than high-grade serous carcinoma. So this is positive for adenocarcinoma. So the next specimen is also coming from a peritoneum washing during the surgery for ovarian cancer, and the patient is an elder female, 70-something. And in this specimen, you can appreciate that we do see a lot of these very bizarre, very high-grade looking cells, along with some bland-looking mesothelial cells. So this is more compatible with a high-grade serous carcinoma with very atypical feature. In the washing cytology for the pleura cavity, it is not uncommon that you can see this type of hyaline globule with some benign-looking mesothelial cell wrapping around this globule. So when you see this globule, you do not interpret this as a carcinoma. This is actually resulting from the washing, so detachment of the mesothelial cell along with some subepithelial, submesothelial, like a stroma tissue forming these hyaline globule. So this is quite common. Okay, and here we do see high-grade adenocarcinoma. So this is also positive for adenocarcinoma. So then we move to our most common specimen, which is pleura effusion with primary lung adenocarcinoma metastasis to the pleura cavity. So this is positive for adenocarcinoma. A different patient, also pleura effusion. Also positive for adenocarcinoma. So we can appreciate that the two-cell population. So the next specimen is coming from pericardial effusion. So again, because pericardium is space outside of the heart, so the heartbeat will produce some force, kind of similar to the washing cytology. So it is not uncommon that you can see more like a larger fragment or flattened sheets of mesothelial cells. But additionally, we are also looking for these two-cell population. The second population forming these more three-dimensional architecture with cell cluster and with higher nuclear atypia. So this is compatible with lung cancer with pericardial effusion. The patient still doesn't have a confirmatory like a pathology report. However, this is the same patient that we see yesterday from her thyroid aspiration. That we will do TTF1 and POXA because we suspect the specimen from yesterday is actually metastasis from the lung. So this is her pericardial effusion specimen. So this also looks like adenocarcinoma. And the morphology is very similar to the thyroid FNA that we see yesterday. Okay, so we don't need to, because we already do the scan on the thyroid, we will see the result today. So this is compatible with lung adenocarcinoma with a dissemination type of metastasis. The patient first came to our ENT department because there were multiple enlarged lymph nodes in the lateral neck as well as an enlarged thyroid nodule. So the ENT doctor do the thyroid aspiration first. That's why we got the thyroid FNA. And then it doesn't look like primary thyroid, it looks like metastasis. So we already informed the clinician that it looks like lung cancer. So again, pleura effusion. The patient has lung cancer, so this is also a lung adenocarcinoma to the pleura cavity. So the specimen was not very well prepared because we see the most of the cells were outside. Because of these, the alcohol fixation was not very optimal, but still we can appreciate that three-dimensional architecture with a glandular arrangement. And when we see through, we do see higher nuclear grade, and some of the cell does have this cytoplasmic vacuole. So this is also adenocarcinoma. Again, pleura effusion. This is a new patient, so we will need to do TTF1 for this patient, but the morphology is again very similar. Three-dimensional fragments, higher nuclear grade, and here you can also appreciate hyperchromasia. This is more prominent in this specimen. So if we take a look of the cell block preparation, you can see these larger fragments with very like a bubbly cytoplasm, some even with some hyaline globule inside. It looks very interesting, but we would do a TTF1 for this specimen to confirm that if this is coming from the lung primary. Finally, this is a fine needle aspiration of the lateral neck lymph nodes. So in the lymph node aspiration, usually if it's benign, we will only see reactive lymphocytes. In this specimen, we start to appreciate more of these histiocytes. Some of the histiocyte has a little bit pigment inside, suggests that it is kind of like a cystic lesion, along with some lymphocytes. So this is a little bit abnormal because in normal lymph node, it won't have cystic change. So then we start to look for if there is other material. So we do see a bigger fragments of epithelial cells. So the cell looks epithelial because it has a very tight, like a cohesive arrangement. The cells show a little bit overlapping of the nucleus, otherwise not very easy to see through. However, in this combination, you see cystic change, you see larger fragments of relatively uniform and low-grade epithelial cells in the head and neck. The most common scenario would be metastatic papillary thyroid carcinoma to the lymph node. So you go to the next cluster and you do see this is samoma body. Okay, and then for the cystic change, sometimes the PTC cell will have changes associated with cystic degeneration. So the nuclear feature might not be very typical for the PTC, which is you are not seeing that it has some elongation, groove, pseudo inclusion. You will become more rounded with a little bit more cytoplasm, sometimes a little bit more bubbly. But this is still compatible with papillary thyroid carcinoma. This fragment is more show classic feature. So you do see elongation, you see some vague grooves, a little bit overlapping of the nucleus. The chromatic pattern was very, very delicate. So this is compatible with metastatic papillary thyroid carcinoma. So because the patient was received sonal guided aspiration, so he already has the image of the thyroid. In the thyroid location, it does have lesion, highly suspect for the PTC. So these can be signed out as PTC. So these can be signed out as metastatic PTC. So if you are very careful, you want to do a TTF1, which is also fine. So here we do see TTF1 is positive. Okay, so compatible with thyroid primary. So here TTF1 serves as a thyroid follicular cell marker, not a primary lung adeno marker. So TTF1 possibly can mean many things, but because of the morphology and the scenario, we know this is coming from the thyroid, not coming from the lung. Okay, so that's all the case for today. Thank you.